Hello there. In this 10-minute medicine talk, I'm going to cover the assessment and management of a patient presenting with hyponatremia. So what exactly is hyponatremia? Well, it depends on the reference range used in your local hospital, but in most cases it will be a sodium of less than 135 millimoles per litre. In a significant proportion of cases, this will be picked up incidentally on bloods. However, hyponatremia can be symptomatic and present nonspecifically, with features such as nausea, anorexia, malaise, irritability, confusion, weakness, and sometimes hyperreflexia. If hyponatremia is severe, this is usually defined as having a sodium of less than 120 millimoles per litre, or the patient having a reduced GCS or seizure activity because of their hyponatremia. In patients with hyponatremia, assessing their volume status is very important to both determine the likely cause and the appropriate management. Features indicating a patient may be hypovolemic include tachycardia, postural hypotension, dry mucous membranes, a reduced skin turgor, confusion or drowsiness, and a reduced urine output. On the other hand, a patient who is hypovolemic may present with a raised JVP, evidence of pulmonary edema, such as bibasal crepitations on chest auscultation, or signs of peripheral edema. Once you have determined the patient's volume status, you can have a better idea of what the underlying cause may be. If a patient is hypovolemic, causes include diarrhea, vomiting, diuretic use, or salt-losing nephropathies. In a patient who is hypovolemic, causes can include cardiac failure, liver cirrhosis, nephrotic syndrome, or renal failure. And finally, in patients who are euvolemic, common causes include hypothyroidism, adrenal insufficiency, syndrome of inappropriate antidiuretic hormone or SIADH, or use of excessive 5% glucose infusions or excessive oral fluid intake. So how do you investigate a patient with hyponatremia? Well, based on your volume status assessment and your likely underlying causes, investigations can be targeted towards those causes. This can include blood tests, such as full blood count, urea and electrolytes, liver function tests, and inflammatory markers, assessment of the plasma osmolality, thyroid function tests, and if adrenal insufficiency is suspected, then an early morning cortisol can be done, followed by a short synaptin test if indicated. Urine samples are also important to collect, both for measurement of osmolality in the urine, but also urine sodium, as this can also contribute to our underlying diagnosis. If a urine sodium is more than 20 millimoles, this indicates that there may be a renal cause for a patient being hypovolemic, such as diuretic use, a salt-losing nephropathy, or even adrenal insufficiency. In a patient with a low urinary sodium, a patient who's hypovolemic may be losing fluid due to non-renal causes, such as diarrhea, vomiting, fluid loss from a fistula, burns, small bowel obstruction, or hypothermia. So how do you manage a patient with hyponatremia? Well, if a patient has severe hyponatremia, then it is important that expert help is sought, as this patient will need to be managed with hypertonic saline, and this needs to be administered in either a HDU or an intensive care setting. In a patient who's hypovolemic, management involves volume replacement with 0.9% sodium chloride. In patients who are hypervolemic, management consists of fluid restriction and treating the underlying cause. food restriction usually being at about 1.5 litres per day. In a patient who is euvolemic, management also consists of food restriction, with slow 0.9% saline infusion of around 1 litre every 12 hours as a starting point. Further investigations will then need to be carried out to determine the underlying cause. When correcting hyponatremia, it is important that sodium levels rise at no more than 10 millimoles per litre in a 24-hour period, unless that patient has severe hyponatremia and are being managed in an intensive care setting. The reason for this is a faster rise in sodium risks osmotic demyelination, which can cause quadriplegia, seizures, coma, and death in extremis. Now, when further investigating a patient with hyponatremia who are euvolemic, it's important to review investigations including thyroid function tests, early morning cortisol, and serum and urine osmolarities to ensure that thyroid and adrenal function are not the underlying cause. SIADH is a diagnosis of exclusion, and so is likely if a patient has normal thyroid and adrenal function, has a urine sodium of more than 20, and has both high urine osmolarity and low serum osmolarity. Further investigations for the cause of SIADH are at this point warranted, and can include CT scans to look for underlying malignancy or neurological or lung pathologies, which can all contribute to SIADH. It is also important to review a patient's medications, as commonly used antidepressants, opiates, proton pump inhibitors, and carbamazepine can also cause SIADH. Management involves food restriction initially to at most 1 litre in a 24-hour period, and endocrinology advice about whether further food restriction is needed or if ADH antagonists are warranted. Thank you for listening.